welcome to a webinar on implementation science and physical activity, how to improve the field through evidence-based practice. This webinar is organized by the Physical Activity section of the American Public Health Association and America's Network for Chronic Disease Surveillance. So it's great to have participants from both organizations here. We have a nice program organized for all attendees with 4 excellent speakers and 4 very interesting talks. And with no further ado, let's start and go right into the action. I'm Noel Barengo. I'm your moderator together with Joseph Leitner. I'm the incoming chair of the Disseminatio section of APHA. I'm also the current president of AMNET, of the America's Network for Chronic Disease Surveillance. Our first speaker is Eric Wiedemann. He's from Washington University in St. Louis. He's a postdoctoral research associate with the Washington University Implementation Science Center for Cancer Control and the T32 training program. He received his MPH and PhD in health education from Southern Illinois University and a master's degree in exercise science from the University of South Dakota. He worked for the SIU School of Medicine Center for Rural Health and Social Service Development, overseeing HRCA grants focused on school-based intervention in physical activity, nutrition, and mental health. His research interests focus on children's health and working with underserved groups through community-engaged research, qualitative arts-based methods, skill development, culture-focused adaptation. He's going to talk about using dissemination and implementation science to improve the implementation, sustainability, and scalability of evidence-based physical activity interventions. Eric, the floor is yours, and welcome, and thank you for accepting our invitation.
All right. Well, thank you very much for that wonderful introduction. I'm going to get my share going here. All right. So, like Noel said, my name is Eric Wiedemann. I am from the Washington University School of Medicine in St. Louis. I'm a postdoctoral research associate and would like to acknowledge the T32 training program, which is what I am funded through at Washington University. And I'd also like to thank Drs. Ross Brownson and Graham Kolditz, 2 of my mentors here at WashU, for providing a lot of the resources and some great feedback for this presentation that you are about to witness. So without further ado, let's get it started. I wanted to start here with this quote from our former President Barack Obama for a couple of reasons, but before we get into that, I'll just start by reading it to you guys here. We have the best medical schools, the most sophisticated labs, and the most advanced training of any nation on the globe. Yet we are not doing a very good job harnessing our collective knowledge and experience on behalf of better medicine. Less than 1% of our healthcare spending goes to examining what treatments are most effective. And when that information finds its way into journals, it can take up to 17 years to find its way to an exam room or operating table. So I think you can probably guess as to why this is where we're starting, as dissemination implementation science is really built around this idea, right? The 17-year gap that we know between when research is created, when those random controlled trials are first conducted, to when we actually see the results from those trials, the interventions that come from those trials actually making their way to any sort of practice setting. And the date that you see there, that 17 years, that comes from an Institute of Medicine report back in 2001, where they did state that it takes, like I said, 17 years. And the more troubling thing with that is that even when it does make its way into practice, the application tends to be very uneven. So it's not a uniform application of that intervention if it does happen to be one of the few studies that makes its way into practice. And this is not an old issue. The NIH back in 2016 released a report where they stated that it takes 14 years for a new drug or medical device to make it onto the market. So this knowledge application gap exists in a lot of ways, in a lot of different fields within science and just in society in general too. So what is this knowledge application gap, and what does it look like? Well, here's a great example of what that looks like within the healthcare system. Again, now kind of an old study, but still a study that has a lot of relevance for us within implementation science, seeing that Americans receive recommended care approximately 50% of the time. So their study, they found based on some phone call interviews with individuals and asking about their health, their current health status, and then relating that to current recommendations related to those health statuses. They were determining that, again, people are just not receiving the recommended care. And what is that issue from, right? Is it, as you see there, it's the consistent evidence of failure to translate research findings into clinical practice. So we're just finding, again, that those random control trials, the interventions that we're finding in the research that are showing promising potential health outcomes are just not making their way into the practice, into those clinical settings where they're actually being able to be applied and be potentially beneficial for individuals. And I think that all kind of comes down to this wonderful slide here that we kind of in the field of science, and certainly I'm guilty of this too. We've often thought that if we build it, it will come, right? The field of dreams. If we build it, people will come. If we build these wonderful interventions, if we create this evidence base for these incredible interventions, then just by proxy, those interventions are going to be implemented because of the amazing evidence base that we've created. But as we know, and as this wonderful webinar is here for, we know that that's not the case, right? As you can see here with this wonderful comic here, the latest research shows that you really need to do something with all this research. We're just seeing that we have a propensity of research without it being actually applied into those practical settings. And so what are some of the reasons for this? Why is this translational research taking so long? We know that it's too slow, right? It takes 17 years. And even so, when it is successful, it's only moderately successful, right? That application is very uneven. It's not spread across uniform, across the entire field. It's oftentimes localized to very specific centers where individuals have, are able to come across it in research journals and say, this is something that would be really effective for us. But beyond this, what does better translation mean, right? So we're talking about this challenges in translational research. So what does that better translation actually look like? It's, I think, also the increase, certainly the increase of using evidence-based interventions. I think that's the easy one, the one that we can kind of all hang our hat on, right? But it's not just the increase of evidence-based interventions, it's also decreasing the use of ineffective, wasteful, or harmful interventions. And this is something within implementation science related to de-implementation or misimplementation, right? Where we're stopping practices, de-implementation, we're stopping practices that are not evidence-based, or misimplementation where we have effective interventions that are either ended or ineffective interventions that are continued. And so again, these are certain different issues that exist within implementation science, as we'll continue to talk about a little bit more within this webinar. So just some key terms here to really kind of root us. We've kind of discussed, I guess, the need, right, for these fields of why dissemination implementation science needs to exist, right? We've discovered that, well, not discovered, we know that research to practice gap exists. And so dissemination implementation research in science has come up to attempt to address that. And so dissemination research, its main focus is to identify the best methods that enhance the uptake and utilization of the intervention. So they're really looking at saying, how can we get other practitioners, whatever that practitioner looks like, mental health, physical activity, nutrition, get practitioners to uptake that and become exposed and understand the benefit of that intervention more quickly. Implementation research, on the other hand, is more interested in setting the fidelity or how well the original intervention was implemented in the real world setting. And so for us, for implementation scientists, we're really looking at seeing how does that intervention fit into the real world setting that it's trying to be implemented in. And so, like I said, fidelity is a huge component of that, making sure that the original intervention is being followed to the best of its ability as it can, so that we're making sure that the evidence base is continuing through. But we want to make sure that we are adapting these interventions to the local context to make sure that they are to be as salient and as effective as possible, so that they're meeting the individuals, meeting the community where they're at. And so with that, the goal of implementation science is to ensure that knowledge and materials produced by health research actually lead to improved population health, right? And how do we want to go about doing this? We want to make sure we're reaching the intended audience. And that goes back to what we talked about with that fidelity and adaptation, making sure that, and same thing with adapting to local circumstances. We want to make sure that these interventions are adapted to the local context within they're in, right? If we go into an area with under-resourced area that doesn't maybe have the financial backing to support a large money sort of intervention, that's something that we need to be aware of, and we need to adapt and make sure that that's not a barrier for this intervention to be effective. Beyond that, we want to make sure that those are implemented effectively, safely, equitably, and in a timely manner that keeps patients at the forefront of decision-making. This is a really important component to talk about equity. Certainly in the last couple of years, with things that have happened in the United States and globally, the understanding of health disparities and the importance of health equity has only become more important in the United States and a lot of the research that we do. And certainly when we're implementing interventions, we want to make sure that that equity is only improving, right? We're not exacerbating any of those disparities that we know already exist. And hopefully in a lot of ways, we're trying to remove some of those disparities with these interventions that are ultimately being implemented. So with all of that jargon out of the way, here's a wonderful slide by Karan that I found incredibly helpful as my recent transition into the field of D&I to really help me understand what we're talking about. As you can see here, the intervention, the practice, the innovation is the thing. So for an example here, if we were going to implement a physical activity program in a school, that physical activity program is the thing. And so effectiveness research looks at whether that thing works, right? So before we even implement it, effectiveness research is making sure that the new physical activity program is actually effective in physical activity. Implementation research then looks at how best to help the people or the places do the thing. So now we are saying, as implementation research, we're going to go into that school and talk to the school administration, perhaps the PE teachers that are implementing this program. And we're going to say, how can we help you best implement that new physical activity program? Implementation strategies are the stuff that we do as implementation scientists to try to help the people, places do the thing. So this may be things like looking at organizational structure, looking at the environment. Are there things within the environment that maybe are barriers to this physical activity program that we can adjust? So we are there to try to say, how can we best help this physical activity program be as effective as possible? And then from there, the main implementation outcomes are how much and how well they do the thing. So as we are going through this entire process, implementation scientists are constantly evaluating the implementation of that program to see how well and to what extent are they actually able to implement that program. So hopefully that provides a little bit better explanation in some language that's a little bit easier to understand for someone maybe not as deep-seated into this field as some of us on this panel. And here I just wanted to briefly kind of show the way that we think about these things as they sit within health services research, right? So you can see their implementation science as a science, both houses dissemination and implementation research. You can see their dissemination research within that is health communication research. And then within implementation research itself is quality improvement science, where you can see that quality improvement. And that was something that has been around prior to implementation science and D&I that still certainly has a strong connection. And I should note here, forgot to mention in the previous slide, but our Canadian friends to the north, D&I is not the common term that they use. They don't call it dissemination implementation science. They refer to it as knowledge translation. So if you're searching through the literature and you see knowledge translation, it's effectively the same. So here is a nice little model, I think, based on the information that we've given you up to this point to kind of, I hope, in my hope at least, give a better understanding of what exactly implementation research is. So what you see here is a pretty common look at the usual way that we treat interventions, right? So what is the thing that we're doing? It's the evidence-based intervention. And what are we hoping to get out of that? Some outcomes, right? If it's a physical activity program, the outcomes, we want to improve physical activity. Maybe it's moderate to vigorous physical activity. Maybe it's less sedentary time. Whatever that outcome is, that's what we're looking for. The difference here with implementation science is we're interested in how, right? We're interested in how well, or how they do that thing, right? So how do you actually implement this evidence-based intervention? And we do that with some implementation outcomes, we in a way to determine the effectiveness of that, we look at those implementation outcomes As you see there are also some service level outcomes there that are related to the Institute of Medicine's standards of care, as this is from Proctor 2009, which is a little bit more focused in mental health and in the healthcare system. But what you can see here is now a nice, finish it off with the lovely little in the middle there. So you can see here is this is where the core of implementation science is, right? We understand that evidence-based interventions are there, and we understand that the outcomes are there, but we're more interested in what's happening in the middle, because we believe as implementation scientists, and as we've discussed here, throughout my presentation thus far, that's where we're going to really make the most change in that knowledge to application gap. So we can take these evidence-based interventions and now actually implement them effectively and hopefully in a much faster period of time. So it's not taking the 17 years that we talked about. So here is that another look at basically that same model, but without all the fancy transitions, just so you guys can see what this looks like. Again, a little bit more, a little bit easier here. And one important thing I didn't mention on this last thing is you can see here, context is incredibly important, right? One thing that I had mentioned previously is, as far as the important components of implementation science, is that fidelity and that adaptability, right? We want to make sure that this evidence-based intervention is being implemented to the best of its ability, but we also want to make sure it's adapted to the local context. And so context is something that's always on the forefront of the mind of implementation scientists. So again, going right back to this slide again, hopefully this makes a little bit more sense, right, as we look back to this. So again, we see the evidence-based practices, that is the thing, right? And those strategies that you see there, those are those implementation strategies, the stuff that we do as implementation scientists to try to improve the thing that's being done, right? So you see there systems environment, the organizational, potential group learning, supervision, individual providers or consumers. There's a lot of implementation strategies. Some will be discussed later in this, but that's just an example of some. But those are the things, those are the tools that we have to hopefully try to improve the implementation of that evidence-based practice. And I know I'm running out of time, so I just wanted to finish up here, and I will throw a few of these references or these items into the chat here. But this is a new field, but it is still very much growing. As you can see here, we have a few different textbooks. I will obviously plug the first one there that you see with the wonderful bridge, because that is edited by Bronson and Kolditz, who I mentioned earlier, and also Proctor, Nola Proctor, who's also faculty here at WashU. We have the Implementation Science Journal, which is a fantastic resource. There's the Dissemination.implementation.org, which has a lot of great models. It's a really great resource for someone maybe not as well-versed in the field to really get a sense of the frameworks and the models that we use. And the last two things I'll point out there, we have the Institute for Implementation Science Scholars, IS2, which is a training program that's housed here at WashU. And the last one there is the TDIRC or TIDIRC. That is through the NIH. It is more specific to cancer. However, it is broad enough that they generally encourage all people from health services research to apply for that. And with that, I will end my talk. Thank you.
Thank you very much, Eric, for a great presentation. And we're gonna have all questions in the end. So any questions you have, you may use the Q&A button and then we can address them in the end. So thank you very much. Our next speaker, Dr. Walker, is an assistant professor of health promotion and behavioral science at the University of Texas Health Science Center at Houston School of Public Health. His research focuses on physical activity promotion and program implementation. He has a particular interest in developing and evaluating the effectiveness of implementation strategies to support the use of evidence-based programs. Dr. Walker is currently working with a team of researchers to develop a comprehensive measure of organizational readiness for implementation and serving as the lead evaluator for the Healthy Zone school programs, a school-based program to support children's physical activity and healthy eating. Dear Tim, it's a pleasure having you here, and Tim gonna talk about developing and tailoring implementation strategies for evidence-based physical activity interventions. Thank you so much for having our invitation accepted for this webinar. Go ahead.
Hi everyone, it's great to be here. I'm just going to share my screen. So So thanks for that introduction. As Noel mentioned, I'll be talking about developing and tailoring implementation strategies for evidence-based physical activity interventions. And Eric did a great job introducing the field of implementation science. And I just wanted to build on that and extend some of what he said. So as he mentioned, implementation is really critical to the success of our evidence-based physical activity approaches. And so I'll be focusing today on implementation strategies. So in those lay terms, this is the stuff we do to help people or places do the thing, which is our evidence-based interventions. So for today's presentation, I'll generally focus on, or more generally talk about implementation strategies. Briefly talk about selecting implementation strategies and the different approaches that we can use, and then take a more focused dive into a specific approach called implementation mapping, and then share an example from some of the work we're currently doing. So implementation strategies are, I think this is the most common definition I see throughout the literature, but they're methods or techniques used to enhance the adoption, implementation, and sustainability of public health program or practice. So you can see that the definition is pretty broad and it can encompass a lot of different types of things. Generally, strategies are classified into these different areas. There can be discrete strategies. So these involve one process or action. So an example of this might be a staff training. There are also multifaceted strategies. So this uses two or more discrete strategies. So it might be combining some type of staff training and then identifying a program champion to help lead the implementation effort. And then there's another form, which is called a blended strategy. This is where there are a number of discrete strategies that are interwoven and packaged together, more in a branded format. So you can think of these more like an implementation intervention. So there's been a lot of research to gain a better understanding about existing implementation strategies and trying to compile strategies and classify strategies that have been used throughout different contexts and settings. And so I just wanted to highlight some of the great resources related to implementation strategies. So these are some great studies that are worth checking out if you want to see sort of the comprehensive nature of all the strategies out there across the fields. And to give you more concrete examples, these are from Byron Powell's work in developing a compilation of implementation strategies. So these are just some specific examples of discrete strategies. So the text that's highlighted in blue, these are the categories, and then each respective bullet is a specific discrete strategy. So as I mentioned before, you can see the strategies can take many different forms, and there's quite a few that people can consider in supporting their implementation efforts. And generally, when we're thinking about which strategies we should be using, I think at the most basic level, we think about identifying factors that influence implementation. And then we want to develop and select strategies that would address those factors. So on this table here, this is sort of a simplified version of thinking if you're trying to implement a program that might be at an organization and you need your staff to implement it. One of the factors that may be important is the staff's knowledge about the program and how to actually deliver it. And so if this is something that's important for your program, you may align interactive education sessions as an implementation strategy to target this factor. So again, this is a pretty basic idea in terms of how to select implementation strategies, but as I'm sure you can imagine, it's a little bit more difficult than just picking and choosing strategies. There are a lot of different challenges that one can have to confront during this process. And so I'm just highlighting a couple here. This is not an exhaustive list. But some of the compilations, they're extremely helpful, but they do have some limitations. If you take a greater focus on them, you'll see that some of the strategies are more connected to certain contexts and settings. So some are more tailored to a healthcare setting versus a public health setting. The compilations also combine a lot of different types of strategies that may actually be qualitatively different things. So some of the strategies can be processes, they can be assessments, or they can even be delivery channels. And so this makes it difficult when choosing what's appropriate for your specific evidence-based approach and context. Another challenge is it can be difficult to link strategies to theoretical concepts. And this is really important because having this theoretical link provides the mechanisms through which the strategies will hopefully improve the implementation efforts. And so that can be a very difficult task. And then also after selecting a strategy, you often still have to develop the content for it. So for the previous example I discussed, if you want to develop some type of staff training, you often have to think about what would go into that staff training to best support the implementation effort. So there have been some methods that have been identified that can be used to help select and tailor implementation strategies. So this is a helpful article that provides a general overview of what some of the different methods can be used to help in this process. And for today's talk, I was going to focus on intervention mapping and tell you a little bit more about this specific approach. So for those who aren't familiar with intervention mapping, this is a systematic approach for intervention development. So this is often what we'd be using to generate our evidence-based interventions. It's rooted in community-based participatory research methods, and it's always taken into account the importance of planning for implementation. However, with the building or with the growing number of evidence-based interventions out there, the developers recognized an additional need to maybe take a more focused approach on the implementation process for existing interventions. And that led to the development and refining implementation mapping. And so implementation mapping combines the concepts and the idea of implementation science with the intervention mapping protocol. So it uses intervention mapping and it's specifically focused for the development of implementation strategies. So this is a great resource for those who are interested in developing strategies to improve the implementation of an existing evidence-based program. So I was going to walk you through some of the steps. So as you can see, there are 5 different tasks. I'm not going to go into all the details of the tasks. I mostly want to present the broader logic so you have a better idea of what the process is about. So for task 1, it's really about understanding the needs and assets of the organization or the place in which you're working with, and then who would be involved with some part of the implementation. So this can be whether it can be about adopting a program or specifically implementing a program. Task 2 is about planning for change. So in this situation, you're thinking about the what and the why. So who would be doing what and why would they be doing it? And then tasks 3 and 4 are about the how. So this is where you're choosing and operationalizing implementation strategies that can target the what and why. And then last is the task 5, which is evaluation, and that's just examining whether the implementation strategy is working. And this is the broader logic model of implementation mapping. So here we're starting with our evidence-based intervention, and it works in a left to right process. So we develop our implementation strategies, which the idea is that they would be targeting determinants of use of the evidence-based intervention. And those determinants would be the reasons why an implementer would do the certain tasks that's required for an evidence-based intervention. And by doing those tasks, the idea is that they would impact the implementation outcomes and then also the effectiveness outcomes. So the logic very much works from a left to right. And whereas the planning process is actually more right to left. So we work backwards as we go through implementation mapping. So usually we start with our implementation outcomes and trying to understand who needs to do what to bring about the change. And so, like I said, we work backwards in this process And that's how we develop the implementation strategies to ensure that it's going to bring about the change that's desired. And so next, I just wanted to share an example. This is really high level in terms of how we're using implementation mapping to develop and test an implementation strategy for active learning to promote physical activity in children. So here our evidence-based intervention is active learning, and we're defining that as incorporating physical movements into academic lessons. And for the current project we're developing an implementation strategy and then conducting a feasibility study to evaluate the implementation strategy. So our first task was to understand the needs and assets. So we were fortunate enough to be able to carry out a pretty thorough needs assessment. This certainly would not always be required, but we were able to do a series of interviews and surveys to get a much better understanding of how our partnering school district is using these active learning approaches. And here we were able to identify that the school leaders and the teachers both played a role in adoption. And of course, the teachers were the primary implementers, but they also received some support from additional staff. And so this was key information to further inform the next steps of the implementation mapping process. And for the sake of the presentation, I'm going to focus more on the tasks of the implementers, which are the teachers, but just know that the implementation mapping process would also take into account the role of adopters and school leaders as well. When we're thinking about understanding the needs and assets, really the first thing we think about are the implementation outcomes. So this is where we're identifying the implementers and what outcome that we want to target. And so within the context of our project, we want the teachers to deliver these active learning approaches as they're recommended. So this really is about program fidelity to make sure they're using the approach the way it's designed to be used. And then as the next task, we're thinking about the tasks that the implementers need to do in order to implement the program with fidelity. So these are almost like these sub-implementation behaviors, but the idea here is that a teacher would first need to agree to use the approach. The teacher would need to incorporate active learning activities into their lesson plans. And so then we continue to work backwards and think about the why. So why might they do that? And we've done some work in trying to identify factors associated with implementation of classroom-based approaches. And we do have some evidence within the school district that teachers' knowledge, their self-efficacy, their outcome expectations, the barriers, and the buy-in are all important factors to consider when they're implementing classroom-based approaches. We also identified some important contextual factors at the school level. So this would include implementation climate, some of the available resources, and the leadership support. So as we keep working through our steps, the next piece is choosing and operationalizing strategies. Now, we haven't quite reached this part of our work yet. So we're currently in the process for this, but we anticipate linking specific approaches to these determinants. So now we're considering doing and developing specific staff trainings that would be more skills-based to help build teachers' skills. We also know that program champions have had really positive impact at some of the schools across the district. And so that can help improve the implementation climate. And we're also considering some type of reinforcement system where school leaders could help recognize teachers who are doing a good job with implementation to further improve leadership support and school culture. So I know I shared a lot in terms of all the steps of implementation mapping and the overarching logic of the approach. And I just wanted to end by summarizing just some of the key concept here. So going back to the lay terms that Eric presented from Jeff Coran's work, implementation strategies are the stuff we do to try to help people and places do the thing. So that's our evidence-based approach. And implementation mapping is a systematic approach to develop the stuff we do to help people and places do the thing. So I just want to acknowledge some of the contributors to the work on this project. And the project is funded by K01 from NHLBI. And thank you for your time. And with that, I'll pass you on to the next speaker.
Well, thank you, Dr. Walker. That was an excellent presentation. Next, we have Dr. Gabriella McLaughlin, who's an assistant professor at Temple University College of Public Health, having just finished her role as a postdoc researcher at Washington University in St. Louis, P50 Center program funded by the National Cancer Institute. Dr. McLaughlin received a master's and doctoral degree in kinesiology from the University of Illinois at Urbana-Champaign before working at Iowa State University as a postdoc research associate, leading projects on childhood obesity prevention and school wellness programming. Her research interests pertain to implementation science and chronic disease prevention with specific applications to school and community programming. Current projects at the ISC3 Center encompass a variety of topics pertaining to health disparities and cancer prevention, school health policy implementation, and school and community approaches to obesity prevention. So with that, Dr. McLaughlin, the screen is all yours.
Thank you so much, Jeremy. All right, hopefully everyone can see my screen. Okay, brilliant. Thank you so much. As Jane mentioned, I'm Gabriella and I'm currently a faculty member at Temple University, having just finished a research position at Washington University with Eric and other colleagues. So what I thought I would do is build on the amazing content knowledge that Tim and Eric have provided so far, but kind of give you a more practical example so that people who are still kind of marinating and trying to digest some of this information can kind of have some practical experience and examples to kind of lend that terminology to. So what I thought is I'd go through basically from what we did in terms of efficacy building all the way to dissemination in the last 5 years. And before I dive in, I'm just going to acknowledge our USDA NEPA grant for funding this work. And this is really what I was doing in the postdoc in the last couple of years to evaluate this program as well. So we had an intervention and it was called SWITCH, which is School Wellness Integration Targeting Child Health. So the evolution of this program really started out from the roots of being a more family-oriented intervention, whereby schools and families were essentially the joining sites together, receiving curriculum materials and intervention programming. And so what you kind of see on this left-hand side is a picture of some of the materials that schools and families received. And the goal of this project is to switch what you do, view, and choose. So it was all encompassing and related to physical activity, nutrition, and screen time. And so under initial efficacy testing through earlier research grants, it was shown that schools that completed SWITCH programming saw increases in children's physical activity and nutrition behavior. We didn't really see an obesity effect, but again, there's lots of reasons why. We can unpack that at a later time. But then a USDA grant was funded to basically take this intervention from an efficacy randomized control trial to a dissemination product. And so what we were able to do is develop a really integrated implementation framework whereby we as a SWITCH team, which comprised multidisciplinary research emphases, and a statewide 4-H extension team, which comprised practitioners and local experts on the ground, we were able to then start training schools, which is in this middle part here, to implement our quality elements and best practices, which I'll show you in just a second. Then what they were able to do is go away, develop programs on their own that they felt would work best for their school context, implement those, and we would be incrementally evaluating their progress and different determinants of implementation over time. And that information then, as a result, if you can kind of see this sort of feedback loop here, gets fed back to our team, and we incrementally make decisions and changes over time. And so from 2015 to now, we've made several changes to the program that they do actually, we're trying to decide now whether that's going to be impacting our internal validity for the sake of enhancing our external validity. And so some of the concepts that Eric mentioned before in terms of that research to practice, we're very aware that when you start to translate and disseminate your evidence-based programs into the real world to enhance dissemination, we are going to have a dilution effect. And so I'll talk a bit about some of the things that we've done over the last few years to study its effectiveness over time. But first, just to kind of show you how SWITCH works, most of these best practices are implemented in the school setting. So things like our PE, our classroom materials, changes to our lunchroom, physical activity breaks, all those kinds of curricular components are implemented in the school setting. However, there is a synergy between the home and the school environment, and that's achieved through our web platform, which now comprises all of our modules, our training materials, and it also provides students, teachers, and parents with ways to log in and track their progress over a 12-week implementation cycle. And so this is just one example of how that screen looks. So over time, what we've been able to do is study the implementation and how specific parts of our implementation and training cycle are shown to either impact change at the school level or indirectly impact change in children's behaviors over time. So we started out with a feasibility study to test the feasibility of our training implementation model. So essentially, do schools like it? Is it actually working? And how can it be improved for future use as well? And that came out in 2018. And then we evaluated some of the key facets of our behavior change hypotheses, such that do students and children who engage in our behavior change practices, such as monitoring their behavior and setting goals, do we actually see changes as a result in their health behaviors? And so we're able to see that those who are using the website more, those schools who are engaging their students more in self-monitoring as an implementation practice, we were also seeing health behavior improvements in those same schools and students as well. So we're starting to see that as we're disseminating this intervention, we're starting to see that there's still certain facets of our initial model that are alive and that are still working as we expand further into the state level. So right now we are at this end stage, and this is a scale-up continuum that was developed by McKay and colleagues. So basically, there's many focused implementations. We have the formative evaluation, and then we go from efficacy testing to a real-world trial. And now we're kind of in this dissemination phase where we've got the product, we've got the things that make it work, and now we're really testing how well can it be disseminated across the state. And so that really led us to a lot of different questions. And the first of those questions was really something that I was interested in my first couple of years in the postdoctoral role. And that really was, how do we know what's driving implementation? What are the determinants of implementation? And what are some of the ways in which those determinants are related to implementation outcomes that Eric and Tim have just talked about? So as mentioned, the CFIR is a really great framework to look at implementation determinants. And so this can be kind of parallel in regards to when people do an outcome paper for their RCT and then a process evaluation paper talking about why or why not they didn't see a change in whatever clinical outcome they had. Really what we're trying to do is to hybridize that and make it so that when we have our implementation outcome paper, we're also trying to understand those determinants as they relate to the outcomes. And so the CFIR is a great model to do that. It comprises multiple different constructs, which are grouped into certain domains. And those domains are, we have an outer setting. So those are things such as policies and relationships with other implementing sites. So in the lens of our school-based studies, are our schools networked within their local region? Are they linked to their local 4H in terms of their county? We also have intervention characteristics, which are simply just pieces of the intervention or the thing. So whether the materials are packaged well, whether it's enticing, whether there's evidence to support how it works. We have the inner setting, which really comprises all of those internal factors within our school setting. So leadership characteristics, our champions, our readiness for engagement. And we also have individual and team characteristics. So who are the people who are leading this? Are they ready for it? Have they been trained appropriately? Are they motivated? And then finally, that implementation process. So we have planning, engaging, executing. And then we talk about our measured implementation, which are things like fidelity, adoption, penetration, etc. And that yields us to our outcomes. So in theory, if we're addressing these determinants of implementation well, if we're trying to mitigate any negative determinants, we in turn hope to see better implementation outcomes that yields to better health promotion and health behavior and clinical outcomes. So this is just one example of how we used our evaluation to drive an implementation strategy that Tim was talking about. So in terms of our implementation mapping piece, we used data from 2019 cycle of switch and put that forward to make some changes for our 2020 implementation cycle. So just one example of how we did that was engaging parents better. So as you can see from our data, and I'll share the link to our article in just a second, but we found, obviously, I'm sure this is not surprising to anyone who does school-based research, but parents were our least engaged stakeholder. And we have a quote from one of these schools: a lot of parents just aren't engaged in anything that the school does. And so what we were thinking is a way to try and combat low parent engagement was to build an implementation strategy around that piece. So when we enrolled our schools, this is again pre-COVID, in the 2019 school year, we had a nice split of our new versus experienced schools. And one really key piece about Switch is that we're constantly expanding. And so we do have schools that have been in our program for a while and some that are just brand new. So one of our goals was, how do we get parent engagement up? How do we understand how to get schools not only to engage parents, but then also to implement better in regards to their best practices? And then how do we understand implementation trends? So that's not only outcomes, but also determinants among new and experienced schools. So our multifaceted implementation strategy was technical support. So we had not only focused training at our Switch conference, which is our training day for all schools, we also started to use communication tactics to provide schools with a meaningful way to engage parents. So we established a newsletter, which was in both English and Spanish, and we were able to train schools on some of the best practices and some of the ways that they could actually engage parents in events and planning and communications, with the goal that they would be more engaged, and then that children would also be more engaged in turn. So in terms of our quality element implementations, as our fidelity score, we had, again, as you can see, there's a bit of a disparity between new and experienced schools, which is what we kind of expected. But in regards to some of our outreach practices, we wanted schools to pick which kind of practices work best for them. And so you can kind of see that there was different tactics employed. Some schools sent emails, some schools sent out a newsletter, some of them engaged them in social media or had an event or used behavioral trinkets to engage them. But what we did see was that our parent outreach score was significantly related with our implementation outcomes, such as fidelity and adoption. So that was kind of showing us that the more the schools that engaged their parents more were actually seeing better implementation overall. And then again, as we can see here through our CFIR coding results, I'm not going to go into too many details about how we coded these data, but essentially what we can do with the CFIR and with data collection guides that are grounded in CFIR, we can take our interview or survey data and assign codes to each of those constructs. So what we found was when we were interviewing our parents, our schools, when they talked about parents, what were the kinds of things they were saying about how parent engagement may have influenced implementation. And so schools were assigned positive or negative scores based upon the answers that they gave. And as you can see over here, the scores for parents were seen to be negatively influencing implementation as well. And this is especially true for our new schools. So we saw a negative relationship between parent engagement and penetration in the school setting. And then again, these are just some extracts from our interviews. And just for time, I don't want to spend too much time going over that, but you can kind of see some of the challenges that we're experiencing, especially in new schools, really address some of these health equity pieces that Hannah is going to talk about next. So some considerations for equity. I think as researchers, we often have a kind of a privileged mindset because we do know what it takes to get an intervention to work in our own mind. But when we come to work with schools that are of different backgrounds, they're serving communities of need, it's really hard for us to sit back and think about how we can change our intervention model and our training process to address implementation. And it's not because they don't value it. It's not because they haven't got the passion for Switch or for any other innovation. It's because they probably have so many other structural barriers to really implementing this with what we call fidelity. So rather than sort of list off a few things we could do in the future, I'm going to show you some changes that we've made to the program in the last couple of months to make sure that we're trying to reach our schools at where they're at, and also trying to engage parents in different platforms other than just a PDF newsletter. So we had online training obviously this past year, and it went really well. We had a lot of schools turn up. We also had more roles included in training that we didn't have before, such as food service staff and also school counselors. who don't have the same kind of schedules as regular classroom teachers or PE teachers. And so again, trying to diversify how we're training schools, I think, is a really big asset. We've also, as I mentioned, made all of our curriculum materials online. So we have our website, which includes all of our modules and some instructional videos. And then we also have a social emotional piece that's built into our modules as well, which is very new to this last year. And then finally, we've started a YouTube channel, which has actually reached far more parents than we ever thought we could do with our initial attempts at increasing engagement. So those are some of the things that we tried to really do and branch out this last year. And a lot of it's through innovation and just listening to what our schools want. And that really drives a lot of our implementation strategies as well. And then finally, we've made research briefs that are a key part of our science communication. As we know, and as Eric mentioned, people rarely read our articles. And if they do, it still takes years for it to get put into practice. So one of the things that we've really put out this year, and they're all on our website for people to see, is how do we establish better scientific communication practices? And so our one-page briefs are a really good way that we disseminate our findings to schools, and they can really make decisions about whether to engage or not, but then also how best to engage as well, and what works best for them. So with that, I will stop presenting, and thank you so much for listening. I will paste a few links in the chat once I stop sharing my screen, just for you guys if you want to look at the website or one of the papers that we published recently. But I really appreciate you guys hanging on, and I will get you back to someone who speaks American now. So over to Hannah.
Thank you so much, Gabby. Great presentation, great talk. As always, it really gets me excited about the discussion that we'll have in like 15 minutes after Hannah has a chance to speak. So next up, we have Dr. Hannah Lane. Dr. Lane is research faculty at Duke University School of Medicine. She holds a master's of public health from George Washington University and a PhD in human nutrition, foods, and exercise from Virginia Tech. She completed a postdoc fellowship at the University of Maryland School of Medicine. She's an implementation scientist focused on improving implementation of healthy eating and physical activity policies in settings, primarily schools, that serve children experiencing health inequalities. Specifically, she applies dissemination and implementation science theories and frameworks to understand the unique organizational contexts that influence policy implementation outcomes in under-resourced schools. So Hannah, thank you so much. And I'm really excited to hear your presentation.
Thank you. Yes, I will. I'll wrap it up, and so hopefully we can have a really good discussion with the folks who are here. So let me just share my screen. I'm sharing the right screen. Is that correct? Great. Okay, so I'm going to talk about implementation outcomes. So I had a nice laugh last night as I was looking at everyone's presentations, because I was starting with this diagram, which I think you've seen several times already today. So if there were a quiz on this webinar, I think that this diagram would clearly be on it. But I'm going to be focusing on implementation outcomes, which serve as indicators of implementation success. So the outcomes of the deliberate actions that we take to implement or scale up an evidence-based practice or intervention. Basically, how well we did the thing that we did in order to do the thing. So they are necessary intermediate outcomes needed to achieve the desired clinical outcomes, which in the physical activity space, we think of as things like activity level, fitness outcomes, cardiovascular disease risk, etc. So I'm going to describe some ways that we can measure implementation outcomes and some reasons we might need to rethink those measures if we want to focus on equity, as our previous speakers have mentioned. So there are a number of ways that implementation outcomes can be operationalized, but two that you might have heard of are Proctor's Implementation Outcomes Framework and NAME. And there's actually some really interesting recent work that looks at the overlap of these two frameworks, and I'm going to provide that reference for you once I'm done speaking. But generally, these constructs are things that can tell us not just if our intervention or implementation strategy works, but how it works, for whom, and why. And importantly, they can also tell us why and for whom things don't work. And I know that it can be overwhelming to think about having to add in assessing implementation outcomes, especially if you, like me, were trained to really look at individual level outcomes related to physical activity. And so I want to walk through some examples of ways that you can integrate that into your projects, and then talk about how we can better operationalize these outcomes to focus on equity. So in thinking about what implementation outcomes you should measure, you really need to think about, instead of just kind of throwing them all at the wall, what's feasible for you to measure and what makes sense for your particular intervention, your setting, and your population. There's a lot of precedent in the literature, and just as an FYI, I did a PubMed search for implementation outcomes and physical activity, and I got 37 results, many of which I read in preparation for this talk and learned a lot. So I'd recommend that you look at some of those to see how implementation outcomes can be kind of measured in physical activity studies in various settings and for various types of interventions and implementation strategies. So I just wanted to provide some examples, some definitions and examples. For example, for adoption, when is that important to measure? If you are looking at something like a mandated policy, it may not be really important to track adoption, but if you have an intervention that's available for work sites, you may want to keep track of what types of work sites are signing up for your intervention as you recruit for your study or project. Or if you're focusing on implementation strategy to improve implementation of a mandated policy, you might want to track adoption of that. In terms of penetration or uptake, this is sort of what, you have an organization has adopted something. So to what degree is that spread or used within that organization? This is a metric you might want to use if you want to know sort of the extent of that spread within your setting. So if you have a healthcare system that has adopted a Parks RX program, how many providers within that system are actually using it with their patients, with what frequency, and then why or why not? Why are they not using it? And then implementation fidelity, which would be sort of, okay, all the providers are using the patient RX program, but to varying degrees of the way that we ask them to do it. So another example would be that maybe teachers are doing classroom physical activity breaks, but not as frequently as they should be to be successful, or they've struggled with them and then made some adaptations to sort of better fit the needs of their students or the confines of their classroom environment. And so along with fidelity, you have to consider adaptation, which is not necessarily a bad thing. And then in terms of maintenance or sustainability, we emphasize this a lot at the individual level, but not enough at the implementation level. So what structures are put in place that allow progress that we've made to be expanded or sustained? So if we have a walking school bus program that we worked really hard to put into place, did the leaders have what they need to carry out the program for another year? Has there been something written into the budget to indicate that they'll be able to sustain the program? And it's important to note that what you'll see in the literature is that generally implementation outcomes use mixed methods. And so you want to have a quantitative component to collect data across all your schools or all of your delivery agent or all of your organizations or all of your delivery agents, so that they can be linked to those more distal implementation or individual level outcomes. But you also often might want a qualitative component to get the contextual information of why and how you've arrived at these quantitative findings related to your implementation outcome. Something we have not historically done a great job with in terms of measuring implementation outcomes is considering equity. Implementation equity is an intermediary to health equity, just like implementation outcomes are an intermediary to health outcomes. And we really have a limited understanding of what drives implementation inequities and whether we are really capturing that with our outcomes. So how are we measuring the success of our implementation strategies? And is it fair to have the same expectation across all contexts and settings? You've heard a lot about this already from Tim and Gabby and Eric about the importance of that context and consideration of various kind of upstream factors. So let's take local wellness policies as our thing. We've been focusing on schools, and so let's focus on these very comprehensive policies that schools are technically required to implement to some degree. The guidance is based on decades of research, really great evidence-based practices, including supporting 60 minutes of physical activity a day, banning unhealthy vending sales, encouraging nutrition education curricula, providing guidelines to ensure that meals and snacks are pleasing to kids, and meet nutritional needs, banning industry marketing, reducing the amount of junk food in classroom parties, teacher reward structures, very comprehensive policies related to physical activity and healthy eating. The problem with these policies is that they are challenging and expensive to implement, and implementation outcomes are poorer in schools with more limited resources, even if they are receiving support strategies. This is something that Gabby just talked about. We might be providing support to them, but it's not really the right type of support, but we don't really have an understanding as to why. And so, therefore, our policies that are really great in practice may actually widen the equity gap. So we really need to do a better job of understanding, instead of just kind of jumping to solutions, why our implementation outcomes vary for whom, and how we can integrate the systemic factors that uniquely face under-resourced settings, such as historical disinvestment, into the way that we operationalize, say, penetration or maintenance. So just really simply, here's my fancy depiction of the problem here. It's obviously not that simple. And Tim and Gabby both described some implementation strategies that are working on really prioritizing, considering equity. But from an outcomes perspective, how do we better incorporate equity as part of our conversation about implementation success? We need to understand how implementation happens differently across schools and understand the historic and structural reasons as to why, and then integrate that better into our metrics, the way that we sort of define what successful implementation looks like. So I'm going to briefly talk about an analysis I conducted it's a secondary analysis of qualitative data collected from 2 studies focused on local wellness policy implementation. And I just want to note, I'm not reporting the full analysis here, just providing a few quotes and examples to sort of drive home the point about the importance of considering equity in our outcome metrics. But feel free to email me if you'd like more information on the full analysis. So we bound this analysis together using CFIR, which you've already heard about, Dr. Shriki Kominika's Getting to Equity framework, and recommendations from a recently published paper by Brownson and colleagues. And the idea was really just to better understand some of the unique factors that are reducing the implementation success in under-resourced schools. So just briefly, I'll describe the 2 data sources. They come from 2 studies, Wellness Champions for Change and Wellness in Rural Elementary Schools, or WIRES. In Wellness Champions for Change, this was a randomized controlled trial that was testing 2 different implementation strategies for local wellness policies in low and middle income elementary and middle schools. We were training and providing technical assistance to teachers to build wellness teams to enforce policies. And then we also had an intervention where we were training, or a strategy where we were training students to be part of that teacher team. And the data here come from semi-structured interviews with the teachers that we designated as wellness champions and the delivery agents on our study team who were providing the technical assistance. And then WIRES is a surveillance study, a national surveillance study. So we have semi-structured interviews with wellness-focused staff from 50 urban and rural schools across the US. So linking our findings very briefly to the implementation outcomes that we've discussed today. For example, penetration. As a reminder, this is the degree to which a practice or an intervention is spread or used within an adopting organization. So with wellness policies, the expectation for penetration is pretty high. These are complex policies, they're comprehensive. They ideally are designed to make changes throughout a school setting. This is a school-wide strategy. But in our schools, and based on the data that we have, we learned that many of the sort of implementation strategies they made it difficult to, or they were insufficient to help schools kind of go from 0 to school-wide. So a lot of these schools, really didn't have anything in place, and we didn't have, as part of our strategy, we didn't have a baseline assessment of kind of where they were starting from. And so our definition of penetration, which would be kind of this comprehensive school-wide implementation, was just not possible based on where schools were kind of starting from. Also, in terms of penetration, our teachers described really struggling to make headway, even if they did make some progress with, working on implementing those policies because of administrative roadblocks. So there was a lack of enforcement or tangible support. So they were doing the thing, but they were doing it on a small scale, or no one was really paying attention. In terms of fidelity, a lot of times the policies were difficult to enforce as intended due to varying types of red tape and barriers for each individual policy component. And it was frustrating as each of those was encountered, and to not have a plan for every barrier. And we often saw that this kind of led to our teachers just kind of doing the easy stuff and not really going beyond to do some of the more broad, the broad best practices, or they were doing things that were not actually best practices because they were easier. We also found that a lot of the teachers were not super motivated because they felt like they didn't have the same value as, you know, other club or team leaders in their school. So they felt like they needed some extrinsic motivation. And then the last thing is just that a lot of teachers reported knowing what their students needed. They knew kind of their home situations, what they were like. And so they made decisions on what to do and how to implement things based on that, such as, you know, having a kid stay in from recess to catch up on their math homework that they know they don't have resources to help with at home. And so this sort of, you know, teachers knowing what students need can be kind of good or bad, but definitely can affect implementation fidelity. And lastly, for sustainability, we heard a lot about challenges with turnover. So new teachers having to start from scratch because champions left, and having to build new relationships and having to kind of essentially start over, and turnover, and we know is very common in under-resourced schools. And then we also had many respondents pointing out how deeply rooted the changes really needed to be able to accomplish what kind of the task at hand. And so relationships and trust need to be established over a period of years at various levels of stakeholders. And there needs to be time to sort of stepwise change that culture and kind of slowly build to a place where these policies could be put into place. And then the bottom line is really just that this level of change is not free. And while it's not all that expensive and potentially could be incremental, and a little bit can go a long way, there were often not financial resources to support. So what does this have to do with implementation outcomes? So a couple of specific take homes from this analysis, and again, a pretty broad view. But I think it's all about how we define implementation progress or success and keep iteratively modifying our strategies to make sure that we continue to make progress on outcomes. So first, we need to engage stakeholders in how they would define implementation success within their school. This is really important in terms of incorporating historical context and tracking progress toward equity. We need to just embrace that adaptation is inevitable, it's going to happen. We need to track it and measure it and anticipate it. In terms of penetration and fidelity, examining prohibitive policies and red tape as part of our outcomes measure, I think is really important in figuring out, you know, why some of the policy components might have been implemented and others weren't. And then incremental measurement of implementation, including, you know, counting, making progress with these upstream factors like shifting culture and leadership support. And then lastly, just in terms of sustainability, prioritizing retention of delivery agents and understanding a little bit more about the upstream causes for teacher turnover. And then thinking about how we can measure that slow build. How can we measure that incremental change in implementation? And just the last slide on future directions. There's a need for more quantitative investigation of the association between implementation outcomes and individual level outcomes, and how inequities influence that relationship. There's a need to continue to pursue methodologies like implementation mapping that have that really engage stakeholders in building strategies and determining outcomes. Natural experiments to study what is working in resource restricted settings. I really like some quotes that we read about schools that really were doing things well, that really did have a culture of wellness, and trying to learn from schools that, you know, don't have a lot of resources but have been successful. And then lastly, just drawing upon scholarship and seeking input from actual health equity experts. You know, we can do the implementation science, but definitely relying on others who have expertise in health equity. So just want to acknowledge funding sources for both of the two studies, and then the K-12 Career Development Award that is funding my time as well. So.
Thank you so much, Hannah. And we have about 20 minutes for discussion and questions. So if you have questions, please put them either in the chat or raise your hand and we can unmute you. I will say that we are recording this, and so the recording will be available to everyone after this. we'll post it online so that you can review all of the talks that were given today. So let's start off with a few questions. I thank you guys so much for this. You know, I continue to learn so much from you and all the great work that you're doing. You know, it seems that we all are kind of like working in schools and you know, really focused on improving population health as well as we can. But we know that this stuff is messy, right? And then delivering interventions to large populations is super tough. I think all of you mentioned some the importance of equity in this work. Can you just talk a little bit about like how do we overcome the social determinants that are really affecting, you know, folks that are getting the least amount of physical activity? What does that look like? And for the folks on the call, what would you recommend that they do? It's a big question, sorry. And anybody can jump in. Whoever wants to try to.
Yeah, I can start just with some of the work we've done, but I think it starts in thinking about some of the existing programs that are out there and choosing good evidence-based programs that are effective for broad populations and that would be targeting those who aren't as active or are experiencing some of the inequities. So I think that's really important, and then using good implementation strategies and approaches to help get those out there. So there's certainly a dissemination approach to make sure that we're getting the right programs to the right people. And so I think that's a key part of thinking through the implementation lens and targeting equity.
And I think too, to kind of go off of what Tim said, and even in his presentation of intervention mapping, I think there are implementation science has a lot of really great tools, or at least borrows from, you know, other community-based participatory research too, to really engage stakeholders. And I think, you know, if we're trying to really think about equity, we really just want to make sure, at least for me, that the right people are at the table. You know, the right people are at the table, you know, to be able to provide input and to be able to push back, you know, when someone like me goes into a rural area that doesn't live there and says, you know, this is not how things are, you know, to have people at that table to be able to say that and to be able to say, we need to adjust these things, you know, things need to be changed and altered. And I think too, you know, just in that the co-creation of knowledge that exists in that too, to really say, you know, this is what we know, but it may not be applicable to your environment. So how can we, you know, meld these two together, these two ideas together to make it most effective?
Yeah, I think just along those lines, just doing more listening. I think as implementation scientists, we like to solution, right? Like we jump to solutions. We're like, okay, well, here's the problem, let's fix it. But I think we need to do more listening and also partner with folks who really do the health equity work, who are kind of like in the trenches doing that work, and not trying to pretend like we're the people who do that work. But so I think definitely doing more listening and not necessarily trying to jump to solutions, which I think is hard for us.
I think also it takes quite a long time to build the partnerships that are necessary for that work to take place. So I think some pressures within the academy don't help, to be honest, because I think that we're so focused on trying to get a grant, trying to write a paper. But one of the things that I think we can all do is to try and serve before trying to intervene. So even just trying to have initial conversations with Philly School District, they have questions they want answered before I can even ask my questions. But that's kind of my job, right, is to start answering their questions first and then build that trust. So, and they have the right answers. They know what works best for them. So yeah, that's the only thing I would just add on to what Hannah and everyone else said.
Yeah, that was going to be one of my future questions. So we have, I think, some folks from HHS on the call. You know, what kind of recommendations would you give to funders and really the folks that are managing the research practitioner system that we all work in? What kind of recommendations from a implementation science perspective would you give to those folks?
I actually think, oh, you want to go? Okay. I actually think funders are starting to get it. I feel like a lot more and more you see opportunities for grants that allow for a couple of years of information gathering and not having to kind of jump straight into an intervention, or grants that facilitate more understanding of mechanisms rather than, again, like jumping straight to an intervention. I think funders are starting to get that this type of stuff takes time, and building in a couple of extra years for that critical kind of partnership, relationship building and learning phase. So my advice for funders who, don't currently have things in place would be to maybe start building in at least a year of prep time. And the other thing is that a lot of times these really great funding opportunities for this type of work have a super quick turnaround time, like a month or two, which not only is hard for universities, but it's even harder for partners, right? And people who you want to engage as part of your study, but they just can't. I mean, that's like an impossible turnaround time. And so I think some consideration for the work that it takes to get community partners on board is also something that funders should think through.
So
I'm trying to think of something to add to what you just said, but it's like Hannah had the same brain. Yeah, the same thing, basically, just give time. Also, it's hard because I think a lot of these grants, they want, even for Ks, you're supposed to show like some initial pilot work. I think that though can be used at one could look at that as a deterrent, right? So like, oh my gosh, I have to have pilot data, but in my mind, I'm like, that could also be used as a way for you to kind of use a little bit of time and do a small pilot study, whether it's cross-sectional data collection. But that again, like you kind of iron out some of the kinks in that relationship. So I think it's one of the things that I like about some foundations. Like I'm going to call out RWJF. They do this really well. They do emphasize the need to build partnerships and that your data doesn't have to show a proof of concept right away, but more of a proof of need. So I like that. So maybe thinking more about that as opposed to like what Hannah said, rushing in with immediate intervention right away, because we know that doesn't work. I mean, Tim presented a really great needs assessment, so maybe just like having that as like a norm to sort of talk about that stakeholder driven piece.
And the only thing that I would add is to kind of echo what Hannah said about, the need to listen and how do you build that into a funding opportunity, because I think that so much of what we've talked about, and I think so much of, the conversation around equity is we know that we don't know, and so it's how do you put that into a grant application to say, we don't know the answer. We're going to hopefully find it, in this process, because most grants tend to be, this is the intended outcome. This is what we anticipate to find, when a lot of times, to listen, we don't know what we're going to find. And so, how to create a space for those sorts of opportunities to be able to be fundable, I think would be really fantastic.
There is a question in the chat. So Merica Whitehall asks, are there studies completed or underway that you guys know of, and this might be you, Gabby, that speak to the effectiveness and efficacy of web-based or app-based physical activity interventions, addressing the barriers that economically disadvantaged people with chronic illnesses face?
I don't know is the short answer, but I'll find out. So if you want to show your email, I'd be happy to chat with you offline. I think that there might be some out there. I haven't specifically done those kinds of interventions myself. And there are some IRB issues which prevent us getting the information for our Iowa project. But I think I can probably rustle up something to help you get to that right answer. So I'll put my email in the chat if you want to email me.
I definitely think there's a lot of work happening in that space. I'm part of the physical activity advisory board for the Society for Behavioral Medicine. And there are a lot of folks in that organization who are working on kind of digital PA interventions. And so I can also put my email in the chat and connect you to some of those folks, because clearly we all do like school-based stuff. And so, not our wheelhouse, but certainly there are folks that are working on that and doing really cool kind of hybrid studies to look at effectiveness as well as implementation.
One of the things that I find really interesting about implementation science is the feedback loop, right? All science, you always come up with more questions than you do answers usually, but for implementation science, I think it's, I don't know how many fold more that you just end up learning and then having more and more questions. For you all, like, what do you think about that? What are some of the things that, you know, in your work really surprised you to learn? And what are kind of next steps for that feedback loop that we all see?
I really like that the field acknowledges and allows for that feedback loop to occur, right? Like, you know, Tim talked about implementation mapping. And Gabby and I were going back and forth about how we both really want to learn implementation mapping because we don't really know, but implementation mapping has evolved from, you know, like iteration after iteration after iteration of this sort of like really, you know, stakeholder engaged process from start to finish of understanding why an intervention may or may not work, right? And the stepwise process has resulted, and I'm sure will continue to evolve, but each one of those steps like counts, you know, and we learn something every time. And so I think that like having the, as a curious scientist, I think is a really nice way to be able to do research, which is to be able to talk as much about what didn't work as what did work. And I also think like there's a recognition that there's kind of a responsibility to do that, which is not something that you necessarily see in efficacy research, where, you know, you're not as encouraged to report your null findings, for example. And so I think that that responsibility is also what kind of ushers our science forward.
And I think another unique thing that I've learned in taking on implementation science is that there are a lot of different fields that are contributing to implementation science. So oftentimes we get stuck in our silos and we take on very focused work. So, but if you go to some of the implementation conferences, there are a lot of health services researchers, mental health researchers, public health researchers. And, you know, each year I've gone to the D&I conference, I've seen more and more physical activity researchers, which is certainly a promising thing. And so I think it presents some challenges in trying to get everyone on a similar page in terms of terminology and how to speak the language. But I also think it presents a lot of different innovative ways of thinking about how to solve problems across settings and contexts. So I think that's something that's been really powerful in taking a greater focus in this area.
And I would kind of echo what Tim said in that I think one of the things I really enjoy about implementation science is exactly what Tim said, is it's very transdisciplinary in nature. And I think it because of its relative newness, I guess, as a field, you know, it feels less empowered to, or the necessity to like reinvent the wheel. So there's a lot of borrowing of things that have already worked. And as for me, as someone that kind of comes to implementation science with a much more qualitative lens, it's really exciting to see kind of the blending of the two, and really the, you know, the understanding the importance of really engaging individuals and stakeholders and really listening to them. So I think in a lot of ways it's innovative in that way too.
So we have about 7 minutes left. I want to give you guys time to, you know, address anything that you want to address, but also, you know, for the folks on the call that want to do more implementation science, what does that look like? So for each of us, let's take a couple minutes and kind of give some advice to folks, or, you know, talk about anything else that you think is really valuable and important for us to hear. Hannah, do you want to go first?
Sure. I think that the amount of literature in the field is a little overwhelming. And so I think I can totally understand why people really hesitate to get started. There's a lot to read, and I mean, it's hard to keep up. And there's, you know, papers coming out every day that are just amazing. And I think something that's important to emphasize is that implementation science is its own standalone like field and, you know, paradigm and approach. And, you know, we all do it in a very applied way, obviously, but there's also a lot of sort of conceptual and theoretical things that have kind of built the foundation of the field. So I think that's one thing that I'll say is just like, if you're overwhelmed, it's understandable because there's a lot to read. Eric mentioned there's a couple of like really great texts that I think are helpful to get started. And I think Eric mentioned them in his talk in terms of some of the ones that sort of simplify the lingo a little bit. Going to if you have the capacity to attend a conference, the DNI, the Academy Health Conference is really great because you have a combination of practitioners and researchers there. And you made me go first, so that's all I have off the top of my head, I think. But I just, I would start with some of the seminal readings that really try to simplify the concepts. I would try to go to conferences and have conversations with people. And I think all of us on this call would be willing to have a conversation with you, because I guarantee you, whatever it is you're thinking you need implementation science for is, something that there's some sort of resource to help you with.
Thank you. Gabby?
I definitely felt like I had nowhere to go kind of after grad school and stuff. And the D&I world is so welcoming, I felt, because everyone is kind of coming from different places. Of course, you have the original pioneers of the field, but so many of those concepts were just taken from health services research and other different fields that kind of morphed into this field. So I kind of feel like, to Hannah's point, like I'm overwhelmed still. We're all overwhelmed with everything. So one of the things that I was just going to say is there's lots of different training and capacity building programs. And Eric and I have been lucky to benefit from one of those, which is a postdoc at WashU. Also, they're actually hiring postdocs. So if you are interested, or you have a student or someone else who's interested, tell them to email either Eric or myself and apply. And there's so many training programs that we can also share with the APHA team as well to provide some of that. But that's it really. I didn't want to speak too much, but thank you guys so much for listening.
Thank you, Gabby. Tim or Eric, either one, sorry.
Well, I won't say much. I think one thing that kind of surprised me, and I think relates to a lot of people, hopefully on this call, is that I think for people that are already, implementing interventions, a lot of times we're doing implementation work without really knowing that we're doing implementation research. Prior to this postdoc and prior to being at WashU, the work I did in Southern Illinois was implementation work without really knowing it. And so I think it's hard to kind of sometimes connect what you're already doing with a lot of what we've talked about with the literature and some of the language. But I think there's a point sometimes, at least for me, there was a point where it kind of all connected, and hopefully that, as you continue in this work, there's a point where it kind of connects and you kind of see these are the things that I'm already doing, to adjust and make sure that this implementation or this intervention actually works. But these are actually, identified strategies or outcomes, or, there's a more operationalized or more structured way of going about that. So in that way, it feels easier to do in some ways because it feels very practical and applied, and something that a lot of us have probably already done in some way or another.
Tim?
Yeah, I agree with what Eric said, in that if you're doing any type of physical activity promotion work, there's an implementation component to it. And so that's just like a natural starting point. And I think the idea, and from me personally, I just started thinking through more of an implementation lens. And so from my personal experience, I started working on a project after getting my master's, where we were trying to test the effectiveness of a classroom-based physical activity program. And it was an effectiveness study, but like I was more of the boots on the ground trying to collect data. And I just saw that teachers were not really implementing it well. And that's what really drove me into this area was, well, how do we get the teachers doing it? Because if they're doing it, we know the kids will be active, given what the program's all about. And so I started thinking through that lens and connecting with people who thought in a similar way. And once I got more connected with the implementation science crowd, it just opened up a new world of opportunity in terms of seeing other people who are really focusing on that aspect of the work. But I think the larger point is, likely you have touched on implementation in some way, and it's thinking more directly through that lens and how that applies to your work. And then it's just catching up with some of the language and keeping up with some of the resources that have been put out there in the field that can really leverage and improve the work you're already doing. So I think that's sort of my thought about it.
Well, I want to thank you all again. Such a great topic and great presentations from everybody. I do want to just, recommend that, Selena in the chat posted the conference for AMNET. So great conference to go to. The physical activity section, of course, would welcome you to APHA. We will be in Denver this year, and it will be a good time. Hopefully COVID kind of helps us out and calms down a little bit, but we'll see what happens. I did want to give Noel just a second here to say any last words as well.
Good. Thank you, Joy. Thanks everyone for the speakers today. Really, it was a great webinar, and we have recorded this webinar, so we're gonna, through AMNET, we have a YouTube link, and probably we're gonna provide it also to our section, feasibility section, so we can disseminate it to all your friends, contacts, and they'll be great. And to everybody, welcome to the APHA annual meeting. We don't know yet if at the moment it's hybrid, so in person and virtual. We don't know what will happen the next couple of months. Probably depends a lot of how we behave, all of us, like with using masks, getting vaccinated. And also for the AMNET meeting, it's end of September. You have the information in the chat. It'll be great to have you at the annual AMNET meeting. We have a great program. We have one of the keynote speakers, Pedro Halal. He is one of the experts in South America in physical activity research. So it will be great having you at this meeting as well. It's nice to have this joint collaboration between our organizations. Enjoy, thanks, great job in the discussion part, and had a great time. And thank you again for everybody for setting this up. And also thank you to the administration of the University of Antioquia, to Sile and Luisa, for all their help in making this possible.
Hey everyone, it is 1:30. I want to be respectful of everyone's time. Have a great rest of your day, and let's keep the conversation about implementation science and physical activity moving forward. Thank you all.
Thank you.
Thank you so much. Have a great weekend. Enjoy.